and it is my honor to introduce our next speaker. It is Henning Andersen, who is a professor in neurology at Aarhus University Hospital. He is going to host the presentation, Immunosuppressive Drug Treatment, Standard Treatment, and I'm probably going to mispronunciate this, but Rituximab. Monitoring of MG patients' clinical scales. Without further ado, please give a warm welcome to Henning Andersen.
First of all, thank you very much for the kind invitation to come here to Iceland. Actually, this is my first time in Iceland, and coming from Denmark, I mean, I really envy you looking out to these mountains. Fantastic view. And also your names, I say, I have just my name, Henning Andersen, but nevertheless, I'm happy to be here. And as probably most of you know, I come from Aarhus, the second largest city in Denmark, where we have Aarhus University Hospital. We just had 3 hospitals until a few years ago, and then we got into 1 hospital, and it's quite new. It's the biggest hospital now in Denmark, actually, and we have about 11,000 employees, 42 specialties, and more than 1,000 beds, including Myasthenia Gravis. So that's why I'm here. And in Denmark, Myasthenia Gravis has been centralized a few years ago, so that there's only the 4 or 5 university hospitals in Denmark that do take care of myasthenia, trying to improve care. We also have quite a bit of acute things going on. So we have this helipad, and in neurology, we're quite happy that we have the big helipad. That's why we're very proud of this helipad. It's not so much myasthenia, but a lot of acute stroke that actually arrive there. So I have, as Niels Erik, also a number of disclosures, and some of these are related to myasthenia gravis, not all of them, but it reflects the development within the area. So as you all know, myasthenia gravis is an autoimmune disorder associated with both generalized but also localized, but symmetrical weakness apart from ptosis. And it can involve a number of different muscle groups, including, as you can see here, both eye muscles, facial muscles, neck muscles, and also extremities, but it may also result in very severe myasthenia, as you know, even leading to ICU. I will focus very much on the guidance article or guidance paper that Niels Erik introduced very well. So I will go through this part, looking into the immunotherapies part. So after diagnosis, and if symptomatic treatment is not sufficient and there's not rapid remission, we should go to second-line treatment, which is prednisolone and azathioprine, or more newly also as an alternative, Rituximab as first-line treatment. This is just trying to give a short timeline. For many, many years, we've had corticosteroids and acetylcholine esterase inhibitors, including pyridostigmine, and they have both shown clear effect. Actually, there are very few controlled and placebo-controlled large trials in these, but no one doubt the effect of these treatments. And then ongoing, and I won't go through all of them, but you can see that these upcoming immunosuppressants and the times or the years from are very much relating to studies. They have been used before, but studies that I'll also go a little bit through in this presentation. And in more recent years, as Niels Erik also alluded to, we have now got some of the new treatments, more specific monoclonal antibodies, like the complement inhibitors and fetal IgG receptor antibodies like Eculizumab and efgartigimod, which have been approved and more probably will come and are coming. So corticosteroids, just a short comment on that. In our guidance, we have given the guidance to have 2 ways to initiate corticosteroids, either what we call an early high-dose oral treatment, giving 0.75 to 1 milligram per kilogram in moderate to severe generalized MG, whereas in more milder versions, mild presentation of generalized MG, we recommend a lower dose can be used starting with 0.25 milligrams per kilogram and then escalate the dose depending on the clinical response. Clinical experience, and I've just taken what we also referred to in our guidance paper, is from Sanders et al., showing that most patients actually respond to corticosteroids. 30% in this overall assessment could get into remission, or 45% into marked improvement. So more than 3/3 of the patients actually experience considerable effect, a positive effect of corticosteroids. It starts within a few weeks, and then it gets better and better within the first 2 months, and even further on, more patients will experience some improvement. However, as you all know, steroids are also quite complicated, especially in relation to both acute, subacute, but also chronic side effects that can become very serious. And therefore, in the guidance, we also emphasize, which is good clinical practice for many years, to introduce steroid-sparing drugs, steroid-sparing treatment, and this should be given to give the possibility to taper off corticosteroids as much as possible. So the first recommendations, I'll just say this again. So for standard second-line immunosuppressive drug treatment, we recommend that patients with MG-related reduced quality of life or functional impairment, despite pyridostigmine treatment, should be offered immunotherapy. In patients with moderate to severe MG, generalized, they should be offered high-dose oral corticosteroids. In more milder versions of generalized, it could be a more low-dose initiation, then escalating the dose depending on the clinical response. Now, looking into azathioprine, which has been the first drug, and we also recommend that in our guidance paper, to use azathioprine as the steroid-sparing drug. This paper came out more than 25 years ago, showing that there is a significant steroid-sparing effect of azathioprine. But you can also see that it's coming after 1 year. And this is a 3-year study, actually. So more or less the first year, there was no difference between the two groups. But after then, the patients on azathioprine had a considerable drop in the need for prednisolone compared to the placebo group. And this also was in the group looking at the patients remaining in remission. There was a much larger group of patients on azathioprine that could stay in remission. So this leads to the next two recommendations, and I'll go through them for all of you. So patients with generalized MG should be given a non-steroid immunosuppressant to achieve a better clinical response and to enable, which is very important also, steroid dose reduction. And we still recommend azathioprine as the first choice to use as the non-steroid immunosuppressant drug. Now, there are also other immunosuppressants, other drugs that can be used, and I'll go through 3 of them. The first is mycophenolate, which is used quite a lot. In Denmark, we don't use it as much. I think in the US, they use it quite a lot. Mycophenolate, actually the largest trial, I also pointed to that in the timeline on the different drugs. This is a paper from Neurology 2008, and actually it did not show a statistically significant effect of mycophenolate. I won't go into all the details, the time does not allow this, but it's just to show you that in this case, actually the statistical significance was not reached, and therefore they concluded that it was not superior to to placebo. There have been a lot of comments ever since and discussions also including trial design, patients included, power, and etc. I won't go into these details. The second drug, steroid-sparing drug that I'd like to point to is the tacrolimus. And this is a Japanese study showing that there is a steroid-sparing effect of tacrolimus. This was published in 2011, showing that after 4 or 5 months, there was an effect. So the dose could be reduced more in patients on tacrolimus. Now, the next one is methotrexate. And methotrexate was a trial that was run in the 2010 to 2014. I think it was published in 2016. It was primarily a US-based study. And it showed actually, I will just focus on the columns on the right. There was an effect on a number of different measures, but none of them did reach statistical significance. So in this case, we still think that there is an effect of the treatment, but it was not really proven statistically. So this leads to the next 2 recommendations in our guidance, and that is mycophenolate, methotrexate, and tacrolimus are recommended as secondary immunosuppressants, and mostly in cases where azathioprine may have side effects or cannot be used for whatever reason. Very importantly also, tapering of corticosteroids and also the non-steroid immunosuppressants should be considered. And this is an area that we have less evidence, less knowledge on, how, when to taper off the medication. And I think this is an area that we should look much more into. But we recommend definitely that patients should be tapered off and very well so in a systematic way. Finally, looking at second-line treatment, I'd focus on the alternative that we have now given in the guidance, and that is Rituximab as first-line treatment. I think most myasthenic centers have given and treated patients with Rituximab for quite many years. There has been ongoing discussion whether it actually is effective or not. And Rituximab, as I think Niels Erik also demonstrated, is a monoclonal antibody, and it hits the CD20 receptor in B cells. So Rituximab is a way of depleting B cells by both direct cytotoxicity, also adhesion molecules, and apoptosis leading to cell death. So Rituximab reduces the number of B cells very substantially. And in 2022, there was a Swedish study, the Renomax study, and this has been part of also our guidance paper, including this, showing that in patients with early onset of generalized MG, patients had to have generalized MG for a max of 1 year. The Rituximab in a very low dose, actually 500 milligram just once, which is lower than we usually treat patients with, showed clear evidence. And this was statistically significant. On the left, you can see the A part of it, that the patients receiving Rituximab, there was a much higher proportion that had minimal disease manifestations even after 16 weeks, and then also continuing that. This also related to the other graph showing the proportion of patients that needed rescue therapy. So patients receiving Rituximab early on in their disease course actually needed less rescue therapy in the year after the treatment was given. There is a study on more chronic patients primarily from the US that did not show any statistically significant effect of Rituximab. I have to say that we in Denmark, we still use Rituximab also for these patients in difficult to treat patients. And in some patients, there is a clear effect of this. Again, it may be a question on trial design, patients included, power, etc. But it has This, especially the Rituximab study has resulted in our recommendation now that Rituximab should be used and considered as to be used as a first-line immunosuppressive drug in newly onset MG as an alternative to steroid and azathioprine. It should also be considered for treatment refractory symptoms, although evidence, as I just said, is weaker than in newly onset patients. Further, there are some more practical issues. There is no clear effect of more than a single dose of 500 milligrams. We have more or less inherited the dosage from oncology and hematology because it started in, as you know, in hematology for hematological cancers, and they give a much higher dose. I think this was the experience also from the MS, the multiple sclerosis area, giving this low dose. But I think it's good to know that even this low dose gives such a good response. And you can also consider a second dose following 6 months after the initial treatment. And then there are some practical issues about serum IgG levels and determination of B-cell populations that one could look into. This was the first part looking into this, and then there was the other part of monitoring in myasthenia gravis. I think we have a number of challenges monitoring patients' severity, right? So I think the problem is, first of all, that the presentation is very difficult. Some patients only have mild symptoms. Some patients have very severe symptoms. So it's very heterogeneous. So it goes from very mild affection. A patient may have slight ptosis on one eye, and that's it. I have a patient that is running half marathon, even faster than I do, unfortunately. So it may be very subtle manifestations of the disease, right? But it may also be very, very severe. So we also have patients quite frequently in our hospital that are at the ICU. So the question is, how can we capture disease manifestations in such a variable disease from very mild symptoms to very severe? How do we monitor MG patients? And I think there are further challenges, because one is that it's very heterogeneous. It's also a problem that symptoms and deficits actually fluctuate. So this is what many of you, I think, experience very much. In the morning compared to in the afternoon, on the evening, it's very different from one day to the other, from 1 week to the other. And it may be very frustrating because you can never plan. You don't know when is the disease more severe, when is it more mild. And this also, I think, reflects what many patients tell us, that the subjective experiences that patients have only moderately correlate to objective signs and deficits. So when you go to the doctor, you go to the nurse, and you complain of this, you complain of problems, you complain of fatigue, and maybe there's an evaluation saying everything is good, so what's the problem, right? So I think this is a major thing that we have to look into. I'm coming from very much research within motor function or motor dysfunction in neuromuscular disorders of various kinds, and we like to measure and quantitate deficits, and I always would like to have some data to actually measure how much is the problem. And as you probably also experience, if you're a patient, you go to the doctor and you would have an assessment evaluation of the muscle strength. This is very basic, but it's the manual muscle testing. And this can be graded 0 to 5, or you can have more rough, just going into mild, moderate, or severe weakness. You could also measure muscular fatigability, and there are some classical tests evaluating myasthenia patients. And this can be very good in some situations, but I wonder, couldn't we measure fatigability more precisely, quantitating the fatigability also using a dynamometer? It could be the eye problems, looking into ptosis or misalignment of the eyes. Can be a very annoying symptom or problem in some patients. Respiratory problems, forced vital capacity is becoming a little bit of a standard thing we're doing in more and more patients. I think it actually helps also. The problem is still that it's only moderately related to what patients experience. Overall, for many, many years, we've had this classification, which is the classical MGFA classification, and it's basically very good to describe patients in quite rough terms, I'd say, going from ocular only being 1, and then it's mild, moderate, severe deficits, and 5 is intubations. But it's also, let me put it this way, it's also a little bit not so detailed, and it doesn't work as an outcome measure. So in all the trials that are now running, this is just basic information of the patients. It's like the blood pressure in other trials, but it's cannot be used as an outcome measure. And we did a review a couple of years ago. There are a growing number of outcome measures in the myasthenia field that actually, in different ways, try to capture and monitor and follow the patients in a more sensitive and relevant way. I won't go through all of these. I'll point to a few of them, but I just want to emphasize on the right side the types. So there are objective ones. There are what we could call patient-reported outcomes. That is solely or entirely the patient that reports something, and that is the measure of the severity of the disease. And then there are also some composite scores, and I think that may also be feasible. I will emphasize on 4 of them, and I won't go into the details, but this is the QMG, which is used in many, many trials. And I think I still believe it's a very good measure. It's objective. This is really measuring a number of different deficits, and it includes all the different parts of myasthenia gravis. MG composite is a composite score. We use that in our clinic at every visit. Takes about 5-7 minutes, and it gives you a very good number, so to speak, of how severe the disease is. This is a patient-reported, but also objective, as you can see on the left. Then there are patient-reported outcomes that can focus on symptom scores, symptoms or burden of symptoms, quality of life, overall impression, and fatigue scales. And very much used now is the MG-ADL, the Myasthenia Gravis Activities of Daily Living Scale, which emphasize or focus very much on the most important symptoms. And this is totally and entirely the patients reporting how much these different symptoms did affect the patient throughout the last week, 7 days. And finally, I focus on the MGQL15, the Myasthenia Gravis Quality of Life, 15 items. So these are 15 statements that actually captures very much. And this has been been through what we call a rash analysis, going from 60 questions or 60 statements to now 15 statements. And we use that also in our daily clinical practice at our clinic. And it emphasizes different aspects of the disease. Some of them are more general, like I'm frustrated by my MG, but it may also be much more specific. I have trouble eating because of MG, etc. I won't go into the details, but show you now just an example, and actually I'll go very quick through it because Niels Erik also illustrated this. This was the first trial that actually showed that some of the new monoclonal antibodies did work. This is Rituximab in myasthenia gravis. And actually, the primary efficacy parameter did not reach statistical significance. I won't discuss this in detail, but the FDA, nevertheless, were so convinced about overall the results that they approved it, and later EMEA did it as well. And this is the MG-ADL, and you can see the red one is placebo, and the blue one is Rituximab. And actually, it captures very much, very nicely, the effect of treatment after 2 to 4 weeks. I had a young woman that was very severely affected, and 1 month later, she was very, very well. So this very much reflects the clinical impression that we have. But also, I'd like to emphasize, there is a placebo effect. So patients having placebo also get better, right? And this is very much in line. So the MG composite, the QMG score, the MGQL15, all of them pointed to the same direction, that there is an effect of Rituximab in generalized acetylcholine receptor positive MG. This is just an example from one of my patients. This is a 19-year-old woman who was diagnosed last year. And so at every clinical visit, the patients respond to the MG-QL15, and we do MG composite in all patients. There's one visit where we didn't do it, but it's just to show that we can follow the patients. And actually, I think it's a very good way to follow the patients. We have done that for more than 10 years now. And so when we, at the outpatient clinic, we sit and discuss, we go in dialogue with the patient. How did you feel 3 years ago? Maybe a difficult question, right? How did I feel? I can't remember. I can't remember either how you performed, right? But this is a way so you can see all the answers, you can see all the scores, and you can actually see what is the development. And when we then, in the medical electronic patient system, we can also see all the drugs that have been given, the dose, etc. It makes it easier for us to get in a good dialogue with the patient and actually find the best treatment for the patient. Finally, I just would point to the fatigue problem, which I think is a big problem. Being in the MG clinic, I hear fatigue very much, complaints of fatigue. And this is a NeuroQL15 fatigue. And this was a 5-scale answers from never to always. I won't go through it, but I think it very much, and that's also what the patients tell me, very much captures the fatigue problem in MG. And actually that did work as well in eculizumab. This was a publication for a couple of years ago showing that in patients receiving eculizumab, there was less fatigue in these patients than the placebo group. Finally, I'll just finish up now by just saying that there are also some very overall impressions. How do you feel? How do you have your daily life? And it's generic prose that you can use in many, many different disorders. And I just emphasize that this can also be used in MG. It just focuses on mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. Some major aspects of having a normal and good life. And you can also do it on the visual analog scale. And we do that also in trials, asking how do you actually feel? What is your worst or your best imaginable health state? And that also is a good way to capture overall how the patient actually experienced this. And by that, I'd like to thank you for your attention. Thank you.
Thank you for that wealth of information, Henning. And as usual, the floor is now open for questions. Are there any takers who would like to break the ice? Yes.
Hi. So I was wondering, you mentioned rituximab possibly being a first-line treatment, or expert consensus saying that it's a first-line treatment for newly diagnosed MG patients. I was wondering if you could tell us something about the side effect profile of rituximab, because you're using quite a low dose. Do you see side effects the same as they do in oncology or hematology?
Well, thank you for the question. First of all, I have to say that it's in generalized MG and it's within the first year. So the evidence is very much based on the Rituximab study. Until now, we have used it primarily in patients that are difficult to treat, patients that have had MG for maybe 10 or 20 years, actually. So my personal experience is very much based on these patients. We started out using the same dosage regimen like the hematologist. That was 375 milligrams per square meter 4 times, which is a very large dose. And we then reduced it to 1,000 milligrams twice with 14 days between. This is very much also the experience from rheumatology. So this is our experience, I think, very much in Denmark. But this is a very low dose. I don't have experience with that. So the side effects, I would say twofold. One is the infusion-related reactions that we have. I had 1 or 2 that had allergy problems, swollen tongue, general problems, a little low blood pressure, but it's rare. The second thing is the immunosuppressant effect, saying that you get too much of a problem and you can get secondary immune deficiency. And I had 2 patients at least that have some degree of of immune deficiency based on this. So I think you have to be careful, and that's also why the recommendations are there, that you should measure the serum IgG and also tests for B-cell populations. You could do that.
Thank you so much for that question. Do we have any other thoughts or inquiries in the room for Henning? Yes?
You didn't come into IVG yeah, okay, treatment, but there came up one question in our group. If you respond to such treatment very badly afterwards, but in long time it's better for the person, is it possibility to give a lower doses or some other way in that? Yeah. Do you understand?
Yeah, thank you. So I think we use primarily, or we use more or less, I'd say, IVIG and also plasmapheresis, which is another treatment very much, that is immune modulating therapy that has an effect within a few days, actually, maybe even just 1 or 2 days. So we use IVIG just a little in Myasthenia gravis. If you have, there is some evidence for the acute treatment, and if you have very severe myasthenia or you have a pending crisis or you're at the ICU, we would use normally plasmapheresis. It could also be IVIG. We don't use it for chronic treatment. So we try to avoid having immunoglobulins in maintenance therapy. I have 1 or 2, but I would not recommend that. If you have side effects of immunoglobulin, you can actually definitely reduce the dose, and that in most cases that would probably help. Just to be cautious also, we had a study in another CIDP, which is an immune-mediated neuropathy, another indication for IVIG, and we found actually a 11-fold increase in thromboembolism. So it's not totally free of risk to get IVIG in high doses. So it really depends. But in chronic maintenance therapy, I wouldn't recommend. I don't know what you think, but I would definitely not recommend that. So we would definitely use other treatments. I hope that answers your question. Yeah.
Any other questions in the room? No? Well, if not, then I will declare that Henning is worthy of a warm applause for his presentation.